Why medical bills look completely random and how they actually work. A hospital once charged $10 for a single Tylenol, not a bottle, one pill. That story became famous because it felt absurd. But here's the part nobody explained. That $10 was never a price. It was a code entry in a database called the Chargemaster, and it represented the nurse who brought the pill, the pharmacist who dispensed it, the barcode system that tracked it, and the liability insurance that covered every step of that process. The number on your medical bill is almost never the actual price. It is a starting position in a negotiation that happened years before you walk through the door. In this video, we are going to pull apart the Chargemaster, explain how insurance contracts turn that inflated number into something else entirely, and show you exactly where every line on your bill comes from. The system is not random. It just was never designed to be explained to you. The U.S. medical billing system has a formal name, Revenue Cycle Management. That name is more accurate than it sounds. It is not called patient billing. It is a cycle, a continuous loop that starts the moment you schedule an appointment and ends when a final balance is paid or written off. 5 players run this cycle. The provider, which is the hospital or doctor delivering care. The payer, which is your insurance company, or Medicare or Medicaid. The patient, which is you. The clearinghouse, an automated middleman that audits claims before they reach the insurer. And the medical coder, a specialist who translates what happened in the exam room into a language the billing system can read. None of these players communicate in plain English. They communicate through codes, standardized forms, and automated systems. That is where the confusion lives. To understand why any of this exists, you have to go back to the 1940s. During World War II, the federal government froze wages to control wartime inflation. Employers could not compete for workers by raising pay, so they started offering health insurance as a benefit instead. It spread fast. Once millions of Americans had insurance, hospitals needed a way to communicate with hundreds of different insurance companies simultaneously. Standardized codes became the solution. When Medicare launched in 1965, the federal government needed a single system that could process claims from every hospital in the country. That pressure built the coding infrastructure we use today. The Chargemaster itself evolved as a byproduct of that same pressure. Because Medicare and Medicaid reimburse at rates that often fall below a hospital's actual operating costs, hospitals inflated their list prices. The logic was straightforward. If government payers are going to pay you less than cost, you need private insurers to pay you more than cost. The Chargemaster became the starting number for every negotiation. The result is a system built on top of a system, built on top of a third system, layered over 80 years. The complexity is not accidental. It is the sediment of history. Here is how the machine runs from your appointment to your bill. Step 1. You arrive. Before you see a doctor, the front desk verifies your insurance in real time. They confirm your coverage is active, whether the provider is in-network, and how much of your deductible has been met. This is the foundation of the entire transaction. Step 2. The visit happens. Your doctor records clinical notes in an electronic health record. Those notes are not the bill. They are the raw material the bill will be built from. Step 3. A coder translates the visit. Think of it this way. Your doctor speaks medicine. The billing system speaks numbers. The coder is the translator standing between them. The coder converts the visit into 2 types of codes. ICD-10 codes describe the diagnosis, the reason for the visit. Type 2 diabetes without complications is 11.9. A broken leg is C2-501A. These codes are used in every country in the world. CPT codes describe the procedure, what was actually done. An office consultation has a code. An MRI has a code. Removing a mole has a code. There are thousands of them. The claim only gets paid if the CPT code, what was done, is logically supported by the ICD-10 code, why it was done. A knee MRI for a knee injury makes sense. A knee MRI coded against a sinus infection gets flagged. Step 4. The claim is scrubbed. Before the claim ever reaches your insurance company, it passes through a clearinghouse. Think of it as an automated proofreader. It checks every field. Is the patient name spelled exactly as it appears on the insurance card? Is the policy number correct? Are the codes compatible with each other? If anything fails, the claim is rejected, not denied, rejected. That means it never reached the insurer. It goes back to the billing department for a fix. This is where many of those mysterious corrected bills come from months later. A typo on day 1 causes a second statement on month 3. Step 5. The insurer adjudicates the claim. This is where the Chargemaster price meets reality. Every insurance company has a contract with every in-network provider. That contract specifies an allowed amount for each procedure code, the maximum the insurer will pay for that service. Here is the analogy that makes this click. Imagine a grocery store where every item has 2 price tags. The big red tag is the Chargemaster price, the list price. The small yellow tag underneath it is the allowed amount, the price your insurance actually agreed to pay. When you check out, only the yellow tag counts. The difference between the two gets erased. That erasure is called a contractual adjustment. So when you see a $5,000 MRI charge on your bill and then a $3,800 contractual adjustment, the hospital did not give you a discount. They erased the portion of the sticker price they were never going to collect anyway. The real transaction was always $1,200. Your deductible and coinsurance are calculated against the allowed amount, not the original charge. That distinction matters enormously when you are doing the math. Step 6. You receive 2 documents. The insurance company sends you an explanation of benefits, an EOB. The provider sends you a bill. These are not the same thing. The EOB is a report explaining what the insurer did with the claim. It is not a bill and does not require payment. The actual bill comes from the hospital or doctor. Matching the numbers across both documents before paying anything is one of the most useful habits you can build. Here is what the billing system does not advertise. When you visit a hospital, you are often not paying one entity. You are paying several independent businesses that share a building. The hospital charges a facility fee. This covers the building, nursing staff, equipment, and supplies. Your doctor charges a professional fee. This covers their time and expertise. If an anesthesiologist was involved, they bill separately. If a radiologist read your scan, they bill separately. Each of these providers may be an independent contractor with their own billing department and their own insurance contracts. Think of it like a restaurant where you get 4 separate checks. One from the landlord for the table and chair, one from the chef for cooking, one from the sommelier for opening the wine, one from the dishwasher's employer for the clean plate. The meal was one experience. The invoices come from 4 different businesses. This is not an error. It is the architecture. The second thing most people do not know. The Chargemaster price is essentially a fiction for insured patients. But uninsured patients have historically been billed at or near the full list price. Financial assistance programs exist at most hospitals specifically to address this, but you have to ask for them. Understanding the machine changes how you move through it. Always request an itemized bill. Hospitals are legally required to provide one. The itemized version shows individual charges by code. Compare each line against what actually happened during your visit. Charges for services not rendered are more common than the system would like to admit. Read your EOB before paying anything. Match the allowed amount and contractual adjustment on the EOB against the numbers on your bill. If they do not align, call the billing department before sending a payment. Know the difference between a rejection and a denial. A rejection means your claim never reached the insurer. It failed the clearinghouse check and needs a clerical correction. A denial means the insurer reviewed the claim and refused it. Rejections are almost always fixable. Denials can be formally appealed. Both look like your claim was not paid. They require completely different responses. If you receive a bill from an out-of-network provider for care you received at an in-network facility, particularly in an emergency, check the No Surprises Act. Effective 2022. This law prohibits most out-of-network providers from billing you beyond your in-network cost-sharing amount in emergency situations. If you received such a bill, you likely have grounds to dispute it. Finally, billing departments expect negotiation. Hospitals have financial assistance programs. Payment plans are standard. A calm, informed call asking for a review of specific line items is a completely routine interaction. The people on the other end of that call have handled it thousands of times. The USS spends more on healthcare administration than any comparable country. Estimates put administrative costs at roughly a quarter of total healthcare spending. A meaningful share of that cost is generated by the complexity of the billing system itself. Hundreds of payers, each with its own contracts, codes, and rules. That complexity produces real consequences. Providers dedicate significant resources to billing rather than care. Patients make financial decisions based on bills they do not fully understand. Claims that should be paid get caught in administrative loops. The system was not designed by a single architect. It grew. Every regulation, every code update, every new insurance product added another layer. The Chargemaster that started as a simple internal pricing list became a central mechanism in a multi-trillion-dollar negotiation ecosystem. What looks random from the outside is actually a highly structured set of rules that were written by and for institutions. Understanding those rules does not fix the system, but it puts you on more equal footing inside it. If this video made your last medical bill make sense for the first time, subscribe. Every week, this channel breaks down one more system that runs quietly in the background of everyday life. How credit scores are actually calculated, how the IRS decides who gets audited, how your property taxes are set every year, and why they go up. These systems shape your money, your time, and your options. Most people never get the manual. This channel is the manual.